I'm Eleanor Wilson, and I'm going to be moderating the second panel here. And I want to thank everyone for joining and for participating, and particularly our three panelists for spending time with us today. This section of the meeting, we really wanted to focus on health system issues and lessons learned during COVID. And I think this is personal for me, is working in a medical center and being a clinical researcher. I know when the pandemic kind of hit and things shut down, we really tried to figure out how to change the health system to be able to continue to do research remotely, change clinical care to be able to do it remotely. And so I think these three panelists will be able to speak to that. First, we're going to hear from Patrick Wildman. So Pat is he's the VP of Advocacy and Government Relations at the Lupus Foundation of America. He is, in this role, he's responsible for leading the foundation's interaction with federal and state government officials and agencies, handling legislative and regulatory issues related to Centers for Medicare and Medicaid Services, the FDA, CDC, and NIH, as well as the Department of Defense. Pat is responsible for developing and implementing strategies to advance the foundation's public policy priorities, leading the organization's annual Advocacy Summit, grassroots engagement with lupus advocates. Pat also leads the foundation's work to elevate the patient voice in drug development, access and health technology assessments, including the LFA's patient-focused drug development work with industry, the FDA and payers, managing the MapRx Coalition, a group of more than 60 national patient organizations focused on advocacy about Medicare Part D. He's also helped lead the foundation's work during the COVID-19 pandemic, including to preserve access to hydroxychloroquine, address unique challenges faced by immunocompromised patients. Pat has over 25 years of legislative and regulatory experience and advocacy experience, including a staff or member of Congress and at the ALS Association as Senior Vice President of Public Policy. He received his BA from Dartmouth College. Pat, are you able to share your screen? Thanks for joining us.
So thank you for inviting me to speak this afternoon. I appreciate the opportunity. And I thought I'd begin just by sharing a little bit more about lupus, because that certainly puts things in context from our perspective on how we've navigated COVID and some of the lessons learned from that experience. So lupus is a chronic autoimmune disease in which the immune system affects healthy tissue. It can affect any organ of the body, but most common in skin, joint, organs. There are three main types of lupus: systemic lupus, lupus nephritis impacting the kidneys, and cutaneous lupus, which is skin lupus. One of the challenges with the disease is it's very, very heterogeneous in that the symptoms mimic a lot of other conditions. The most common symptoms we see are pain, extreme fatigue, hair loss, cognitive issues, physical impairments, and a number of others as well. And lupus, while it is typically chronic, it certainly can be fatal, particularly when it gets into the organs. On average, it takes about 6 years for someone to get a diagnosis, and that's a challenging process. It involves seeing multiple different providers. And when people are diagnosed, there's a number of different treatments that they may take. On average, around 8 different medications that they take, sometimes as many as 20 or 30, depending on the individual patient. And among those drugs, most are off-label. We have one drug was approved specifically for lupus about 10 years ago. That drug is Benlysta. And at the end of last year, that drug received a new label, or a new change in the indication to include lupus nephritis. So it was just systemic, but now it's lupus nephritis as well. And then we had another drug approved in January for lupus nephritis. So 3 drugs specific to lupus that are out there now. There are up to 1.5 million Americans living with lupus, and 90% are women. Certainly men do get it, but the bulk of the cases involve women. And women of childbearing age, so age 15 to 44 or so. And we do see lupus in children increasingly. In fact, a lot of what we see is people that may not get diagnosed until their 20s, but did exhibit symptoms as teenagers. And lupus does impact minorities at higher rates, particularly African American, Hispanic, Asian, and Native American women. are up to 3 times more likely to develop the disease than white women. When it comes to COVID, some of the things that are a little bit unique for us with COVID is that because of the nature of the disease, because we have people with lupus have a compromised immune system, either because of the disease or treatments that they take. And that makes them at greater risk of any infection. But certainly with COVID, coming into COVID, that was obviously a huge concern. While at the beginning of the pandemic, we didn't realize this, but as things progressed and there's more data out there, with people with lupus, they're at risk of more severe COVID, more severe disease, and worse outcomes. And a couple of the other challenges that we have faced with COVID is that the risk factors that are common, or that make someone at greater risk of developing COVID, are also things that are common within people with lupus. For example, high blood pressure, kidney disease, diabetes, and other things. And another challenge that we faced and continue to face is that the symptoms of lupus are similar to the symptoms of COVID. We had a lot of reports throughout the pandemic of people just not sure whether it's lupus or COVID, and people questioning whether or not they need to get tested, which brings in a lot of other questions for folks. So that kind of gives you a sense of some of the issues that we face coming into the pandemic. And early on in the pandemic, it wasn't, we really didn't know where this was going. We didn't know how significant it would be or how severe it would be. And at first, a lot of our approach was treating it not unlike flu season, in that with people with lupus are very sensitive to flu season and things like that. So hand washing was not, people really being careful of washing hands, distancing, not going to work if you're sick, staying away from people who are exhibiting symptoms. Those types of things were not unusual for someone with lupus. They're very sensitive to the fact that they're at greater risk of catching an infection. So at the beginning, it was really being ultra cautious. Then hydroxychloroquine came along, and I'm going to explain a little bit more about that in a second. But that really changed everything for us. But there's some, and that was pretty much one of the things that was unique to our population, and as well as rheumatoid arthritis, which hydroxychloroquine is also indicated for. But some of the other challenges that we faced were I think common among a lot of conditions, particularly the immunocompromised. But we had challenges with accessing physicians, because it's important that people need to see their physician, not simply telemedicine, but it's important to see their physician and to take certain tests that need to be taken to monitor disease activity and provide appropriate intervention. Treatments, the treatments I mentioned earlier, specific to lupus, the primary one is an infusion, so people have to leave their home to get it. There is a subcutaneous option for that, but the bulk of people get infused. So that created a lot of challenges too. And the fact that people have to travel. Not everyone has ready access to either a physician, a rheumatologist specializing in lupus, or to get an infusion. So some people do have to travel a considerable distance, which certainly created problems during the pandemic. And as I mentioned, telemedicine, it certainly is a benefit and helped, but it's not a substitute for the in-person visit with a physician. And there's actually some research underway now where we're looking to see what impact the pandemic had on outcomes. Were people delaying accessing care because of the pandemic, and what did that result in? We have a suspicion that it is worse outcomes. So that's kind of some of the challenges we face, but I'm digging a little bit more into hydroxychloroquine and the experience there, because it was unique. And I've had a couple times during my career where I've had these moments where I'm like, the unexpected happens. in a previous position, I was at the ALS Association, and I was there for the Ice Bucket Challenge, which I think most people are familiar with. And that was one of those moments like, wow, this is absolutely incredible and certainly unexpected. Hydroxychloroquine was similar, but for not good reasons, obviously. We did see this coming to a certain degree. There was some research in China looking at hydroxychloroquine early during the pandemic, and we thought that may, if that started to show some promise, that we may have some challenges here. It wasn't until a certain individual, who shall go nameless, mentioned hydroxychloroquine on national television and indicated he was taking it. And that's really the kind of moment for us. And what we saw was pretty quickly shortages of the drug. This is a drug that's been around for 50 years. And it's pretty much the same people taking it every year, same number of people, but we saw an explosion in demand. And the problem, and as I've talked about this experience, the problem wasn't one specific thing. There were a lot of different challenges that we faced. One was a supply issue, just because the demand increased, so we had a supply issue. So that was one challenge. But then we had prescribing issues where physicians who've never before prescribed hydroxychloroquine started prescribing it. They prescribe it not only for their patients, but for themselves. They prescribe for their family members. We see stockpiling of the drug by every player in the health system, by providers, so physicians and physician practices are stockpiling the medication, hospitals, health systems. Across the board, everyone kind of holding on hydroxychloroquine, and in the process, holding on to it for use in COVID or for the potential future use in COVID. So a lot of, early on, not much was known about this and its effectiveness in COVID. So people were really anticipating that it'd be effective in COVID. And because of that, they limited the access to it for people that currently needed it. So people with lupus and rheumatoid arthritis primarily. So we saw across the board, and I list at the bottom here, states, health plans, hospitals, health systems, providers, pharmacy boards, all of them in some way were limiting or having a say in who was getting access to hydroxychloroquine. In some cases, they were limiting it to only for use in COVID. They were certainly putting in place quantity limits where people couldn't get a full fill and get 7 days worth, maybe 14 days worth of drug. If that, prior authorization requirements, where folks had to go through hoops to get it for people with lupus. Or in some cases, you had to have an existing script. So people who are newly diagnosed with lupus and prescribed hydroxychloroquine were having very significant challenges getting the drug. And we had a number of people that just were not able to get drug. So a lot of different challenges, a lot of different parts of the health system played a role in that. And because of that, that required kind of our solutions, and I'll try to go through this quickly. Our solutions were were systemic, were throughout the health system. There was no single solution. We engaged the manufacturers of the drug. We ultimately ended up working with, I think it was 12 different manufacturers, some of whom that had not previously manufactured the drug. So that helped us to increase supply. There were some other challenges there, which I won't get into, that had to do with foreign supply, and some challenges with India, which there are some challenges there, but we did work with the manufacturers. We also looked for different sources. So not necessarily the large pharmacy chains, but also the mom and pop pharmacies on the corner, and compounding pharmacies as well, and try to find other sources of drug for patients, even all the way down to the local level, trying to direct patients to where they can find the drug. Certainly working with federal agencies across the board, with the main health agencies in the U.S. and the White House Coronavirus Task Force. And then, again, all the other different players, pharmacy boards, the Hill and state governments. We saw the states doing 50 different things. Some states were really doing their part to help preserve access for people with lupus and rheumatoid arthritis. Some were focused on COVID only. So it was a challenge to try to navigate the states and work with the different pharmacy boards to make sure that our patients had access to the drug, recognizing the broader implications for the pandemic and the broader public. And a big part of what we did was we helped patients navigate the process, create a lot of resources and tools to help them understand what was happening and help them get access to the care they need. But it was a significant challenge. And we're still facing some challenges today, not with hydroxychloroquine, thank goodness. That resolves itself within probably about 2 months, 2-3 months, once more evidence came out about the efficacy of the drug in COVID. So we now have a glut of product on the market, so which is a good thing. But we still have challenges, particularly when it comes to vaccines. And with lupus, the concerns, probably one of the chief concerns we get from patients is whether vaccines are effective and effective within lupus specifically, because we're immunocompromised, and also because of the treatments. There's concern whether the treatments that people take might reduce the efficacy of the vaccines. And then there's certainly concerns with vaccine hesitancy and access to the vaccine from underserved communities and minorities, which are a good segment of our population. So there are some challenges there. And these other two things that I mentioned here, public guidance and reopening, the big concerns here is, and I'm going to get to them in a second about lessons learned, but the big concerns here are not simply guidance for our communities on what we should do when it comes to reopening, when it comes to taking the vaccine. A lot of that, because there isn't a lot of information out there, a lot of hard data, a lot of research, is speaking with your physician, which is a good thing and something we always recommend regardless. But the bigger challenge is really communicating to the broader population as we're reopening, and as people are getting out, and that mask mandates are lifted and distancing, that all that changes. Is that for the general public, that's all well and good, but there's a lack of communication, noting that there's segments of the population, the immunocompromised specifically, who it may not be safe, and that people need to be cognizant of that, of those populations who may not either be vaccinated or the vaccine may not work, who are generally just at greater risk overall. So that's a concern that we have, and especially as we do reopen, in that there are flexibilities provided for people that are at greater risk, and for people we just don't know the answers to these questions, whether that's school, whether that's work, or whether that's accessing healthcare. So those are some of the challenges that we have continuing. Some of the lessons learned, I think communication, really getting sound, consistent, coordinated communication across the health system. The hydroxychloroquine example is a really good example of how there's so many different players, and they were doing different things at different times, saying different things that created a lot of challenges. So I think consistent communication and coordinating that within the health system, and making sure that those communications are informed and evidence-based. Certainly early on, a lot of it wasn't, and that was a challenge. But also engaging the communities. Our community, I don't think we really was engaged at the beginning, certainly not at the beginning. And it was a lot of focus on the general public, which I certainly understand, but I think there were some challenges that we experienced, not just our community, but others, that could have been mitigated if we had been brought in earlier across the health system, not just in certain parts of it, but across it. And I'll also emphasize, and I'll end with this, and kind of pick up on something that Senator Van Hollen was saying, is that it's one thing to communicate with the providers, but it's another thing to communicate with patients and patient organizations. because we have a different perspective. Patients may have a different perspective on certain things than providers and physicians. And it's not trying to say that the physician perspective isn't important, it's critically important, but so too is the patient perspective. And it's very, very important that the patient community be engaged in these issues because we do have a unique perspective and a unique experience. So with that, I will conclude. Thank you for the opportunity, and I'll turn it back over to you.
Pat, thank you so much for sharing that. I really appreciate it. That's such a good perspective. Okay, I'd like to next introduce our next speaker, Angela Hagan. So Angela Hagan comes to us from Humana. She's the Associate Director in Humana's Office of Population Health. She leads Population Health Insights and with a focus there on health-related quality of life, social determinants of health, and health-related social needs. Her team focuses on health-related quality of life population surveillance, integration into clinical operating models and interventions, and social determinants of health analytics around clinical trend drivers and quality metrics, research catalog and agenda, and the public policy environment for evaluating social determinants of health. Previous work at Humana that she's done includes leading member clinical engagement strategies. Prior to joining Humana, Angela worked with a variety of nonprofit and education organizations in research and development, marketing, communications, and PR functions. A native of Illinois, she holds a BA in economics from the University of Illinois at Urbana-Champaign. She claims Louisville, which is Humana's headquarters, as her adopted hometown, which I'm excited to hear as a fellow Louisvillian. After earning her Master's of Public Health Administration with a public policy focus and a PhD in Urban and Public Affairs from the University of Louisville. So Angela, thank you so much for joining us. Are you able to share your screen so that we can see?
And here I am to talk to you particularly today about our experience during the pandemic and just in general with a lens on social determinants of health, health-related social needs, because that's the focus of our team. But I'll tell you a little bit also about the overall enterprise approach to our members as we serve during the pandemic as well. So I'll start out just telling you a little bit again about what our bold goal team is, just because you know, that and our population health strategy is a little bit different from population health strategy and more clinically focused organizations. I'll tell you a little bit about what we do in terms of how we focus on health-related quality of life and social determinants of health, which really have a very patient-centered focus, right? These are self-reported measures, so we do have a strong focus on patient-reported outcomes. And then I'll kind of hit some of the highlights for how we've responded in the past year. A year and a half now. Gosh, I mean, we've all been working from home since you know, mid-March, so, and probably aren't going to be heading back until this fall. So, so our bold goal is a team, a population health strategy team that is situated in our Chief Medical Officer's organization at Humana. It's the Office of Health Affairs and Advocacy. And really, our mission, our work is about improving the health of the people we serve and the communities we serve by making it easier, knocking out some of those barriers to achieving best health. And, you know, when I say communities, we do a lot of work in specific geographic communities, as well as when I think about communities or population segments as well. So I won't go through every detail here, but just kind of giving you a timeline for how we've been doing this work. It started about 7 years ago in San Antonio, where we were looking at ways to collaborate across communities and bring together organizations across sectors to, you know, public, nonprofit, for-profit, who are coming at health, different kinds of organizations, you know, hospital health systems, local government, providers, nonprofit organizations that may be doing food delivery or housing, you know, health in all policies kind of approach. And we chose initially, you know, because we are going across communities, we chose health-related quality of life, the CDC's Healthy Days measure, as the way we're going to demonstrate how we're improving health. Now, we've evolved along the way and folded in health-related social needs and social determinants of health, because those are strongly related to health-related quality of life and to clinical outcomes. You know, we do a lot of this work through through partnerships at the local, state and national level, and with provider communities. And, we partner with universities, and we've expanded to different lines of business. We focus on Medicaid membership and Medicare primarily. We've scaled up our screening of social needs, and we're actually testing out how do we address these needs and through our benefits on plans to be able to address things like providing food so that people can take their medicine as prescribed with food, not take it on an empty stomach. So, and we're even evolving in this past year to this community of opportunity work where we're folding in health equity to this work as well. It's been on our radar for a long time, but of course this past year really brought long-time structural and systemic inequities to the forefront, and especially in our hometown in Louisville, Kentucky. So let me tell you a little bit about what we do in terms of our self-reported, patient-reported, patient-centric measures. We use the Healthy Days measure, as I mentioned before. Some of you may be familiar with this. It's used commonly in public health departments across the country in their annual BRIFIS, Behavioral Risk Factor Surveillance System Survey. We also use it at Humana, and we survey hundreds of thousands of our members every year as a population pulse to see, to compare year over year within communities. We also use it. We use it in pilots and interventions as a leading indicator. But basically, we're asking people, in general, how their health is. Is it excellent, very good, good, fair, poor? We're asking them in the past 30 days, how was their physical health? How many of those days were not healthy days, physically speaking? How many of those days in the last 30 were not mentally healthy days? And we're not talking necessarily mental illness, but stress and emotional challenges. How many of those days were not good? And we also ask about functional limitations. But we do a lot of focus on the middle two questions: the physically healthy days or unhealthy days, and the mentally healthy days or unhealthy days. And as you can imagine, not only in our membership, but across the country, the mentally unhealthy days and stress has gone up for everybody, across the country. We do report every year in an annual progress report what we see and observe in our own membership, but often it will be mirrored in other public reporting measures of well-being. One really interesting thing that we've learned along the way over the past few years, and it's not surprising. I mean, people are really good judges of their health, right? If you ask someone how they feel, it often corresponds with clinical health, right? So when you look at someone with a condition like diabetes, chronic condition, COPD, I mean, they're not all on here, but, heart failure, anything like that, you're going to have poor health-related quality of life. And, the older you are, likely you're going to have more health problems, right? We know that disease prevalence increases and so forth. Group when you see on the far left here, group means more a younger, traditionally commercial kind of plan membership. So those are a lot of younger, healthier working age people. They have, on average, fairly low number of unhealthy days each month. I mean, everyone has some stress, right? But it's a lot lower on average than you would see in a Medicaid population with a lot of needs, or an older Medicare population. But what's really striking about this is you see food insecurity and loneliness called out here as social needs or social determinants of health that have a huge burden on health-related quality of life. When someone is food insecure or severely lonely, their health-related quality of life is poorer than someone who doesn't, or who has depression. Now, these are not mutually exclusive categories here on the bottom, but to me, it still speaks to the burden on health-related quality of life that is present with these social needs. And you could have diseases going on at the same time, but to me, it's an additive compounding thing that makes things worse on clinical health. We also see that those social needs, not only in our own data, but in the literature correspond with a whole host of poor clinical outcomes. I mean, I don't think I have it all in the deck here, but I can tell you that when you're lonely, you are several times more likely to be readmitted to the hospital in a year. You're several times more likely to develop dementia. When you're food insecure, there's a strong relationship between medication adherence, between blood sugar, A1C control. So all of these things have a huge tie and burden on your clinical outcomes as well as your health-related quality of life. And we've done some large-scale surveying too with our members to understand how prevalent these needs are in populations and how they co-occur at the same time. So just like disease, health-related social needs can be complex and comorbid. So this is, the green is our Medicare member population representative of them. We surveyed several 100,000 of our members. It's a very, very representative, generalizable population to our overall Medicare population of a few million members. And we see that the prevalence, so 52% of our members have at least one social need. The top one is financial strain, and that's not just low income. That's, people could be above an income threshold that qualifies them for some subsidy programs, but still have trouble affording some of the basics, in terms of rent or having enough money for their groceries or transportation or other necessities, utilities, right? Or medication. Food insecurity, loneliness are other top ones. Actually, loneliness is the second most prevalent social need we see in our senior population. We also see it as very common in we have most of our Medicaid membership is in Florida. We do have some Kentucky Medicaid membership, and we've just surveyed them. And we also see that loneliness is very high among that population, which is traditionally a younger population, right? You don't see the results here, but we also followed a cohort of people over the year, and we did see that loneliness increased over the year, which among our own membership, among our senior population, and among our Medicaid population. And that was mirrored in the nation as a whole, right? We've all seen those surveys out there. We've seen reporting on loneliness increasing. Now, one of the things that we didn't see increase in our population, and I'll tell you a little bit about that during COVID, is we actually saw that we were able to stave off, increasing food insecurity and some other basic needs because we were proactively reaching out and trying to address that with several solutions. But I just wanted to give you a flavor here to see how prevalent some of these social needs and challenges are. And we also on the back end, of course, are looking at how the combinations of these needs or multiple needs or individual needs relate to a whole host of poor clinical outcomes and why it's so important for us to address these. And here's just another example of social needs. And this across the bottom, you'll see is the increasing number of comorbid, co-present social needs. And you can see that the cost of care, which is that light green number, increases with the number of needs that someone has. And you can also see that this is a look at A1C, HbA1c control, and you can see that compliance or control of blood sugar decreases with the number of those social needs. We see this with a host of other disease measures, but I mean, it's not surprising, right? It's intuitive, but we're able to see this in our own data. So just wanted to, we serve a lot of people with a lot of different conditions and who have, all these chronic conditions make people much more susceptible to this time during COVID as well. So I'm trying to tie all the threads here together. But I wanted to help you understand why we are so focused on these social needs and their ties with health outcomes. So let me talk for a few minutes about what's been happening at Humana over the past year or so. in terms of how do we make health easier and try to keep people well during this global pandemic. So we did a lot of things across the organization. Social determinants of health was a big part of that, right? I've mentioned that. Of course, we were also doing things to make testing for COVID affordable, accessible, removing copays, anything like that, removing that cost burden for testing and for COVID-related charges. We were working on getting telehealth access set up for members, right? And doing things in the home as much as we could, whether through telehealth or through safer home visits. We also worked to do anything we could to help our providers and members in terms of affordability. We fast-tracked a lot of things around. I think we had something like 4,000 telehealth visits for January and February, and then scaled that up, March through May last year, just to about 10 times that amount, what we were normally seeing. So we rapidly scaled that work up in terms of getting that kind of access for people. Now, we also worked to, as I said, to waive a lot of those out-of-pocket costs, and we did other things like allowing early prescription refills for people, so they didn't have the burden of trying to get out to places, or they could get them delivered to them, and make fewer trips out. On the provider side, we were trying to make it easier and get rid of some of those authorizations burdens that happened to delay care, and expedite some bonuses for them to help them get their work done and improve quality. And we took some of the administrative burden off them as well. Now, we really wanted to assess both medical and social needs, and we have home-based teams and telephonic-based care teams that are reaching out to our members, whether via telehealth or telephone, or actually being able to go to their home. And we have a basic needs program that we really set up and scaled up in this past year, where care managers, clinicians, were reaching out to members and asking them about all those needs I mentioned. Were they able to get their prescriptions? Did they need to see a doctor? Did they need safe access to a doctor? But also, did they have some needs about, did they have needs for food or other kinds of strains on them in their home that may have been getting in the way of their best health? We were screening them for food insecurity, screening them for loneliness and isolation, and other needs, and trying to not only screen them and ask them, but address that. We began, making sure they had enough medication on hand. We set up emergency meal deliveries. We started doing some extra benefits tests for people so that we could connect them to either healthy food benefits or that we could offer, or through resources in a community. We were able to provide shelf-stable meals for people who had storage ability. We were fielding thousands of requests a day for food and other assistance, and really trying to scale that up. I can tell you a little bit more about that, but we've served well over 1 million meals, and those were numbers through, I think, early Q1, and we continue to do some of that outreach. Let me tell you a few more of our initiatives that we've been working on during this time that really pertain particularly to these social needs. And PAPA is a program that some of you may have heard of. PAPA Pals is this social entrepreneurial group that is kind of like companionship on demand, and it pairs trained college-age, typically students, to be companions to seniors. They can help out with non-clinical types of things like delivering their groceries or helping them set up their iPads so that they can communicate with family members across the country. Go play chess with them, change a light bulb, whatever, but providing that kind of companionship. Now, one of the things we did during COVID was to offer that virtually as well. as the in-home visits. So people felt safe, but still had a connection. We started a friendship telephonic line to connect with people and we were getting inbound calls from people who were lonely, so they had someone to connect with. We worked with a whole consortium of organizations to start this Far From Alone campaign to reach out to people and let them know that they had some connections to others and that they were not alone and feeling lonely and isolated. And of course, I did mention our basic needs efforts around the food insecurity work. And then, we just worked on expanding platforms and technology to connect people to other resources immediately in their communities. So again, we're still getting through this COVID time as a health plan and trying to help people. And we know that there are some new normals, and it's hard that are going to be emerging. It's sort of hard to really envision what that new normal will be. But, we know that data are going to be very core to it, an ability to collect more data, stratify it, and understand needs better, to partner together cross-sectorally. We have to think about our payment models to support this kind of work. And we know that health inequity has to be a part of the solution to expand access to coverage and resources for especially vulnerable and marginalized populations. And we are seeing that right now in the data that we're collecting through surveys and trying to act on. So I just wanted to, again, just give you a quick overview of the things that we've been thinking about from a plan perspective, and because we do deal with a lot of older, sicker, vulnerable populations. So thank you.
Thank you so much for sharing that. It was really interesting to see that data too and know how you're tracking that. That's very cool.
Sure. Yeah, and if anyone's interested, you can always go to our population health website here to see some of our reporting and our resources around social needs.
All right, for our last speaker this session, we have Dr. Andrea Levine, who I'm happy to say I get to collaborate with here at University of Maryland. She's in the School of Medicine. So Dr. Levine is an assistant professor of medicine in the Division of Pulmonary and Critical Care here at the University of Maryland School of Medicine. She's the program director of the Critical Care Medicine Fellowship. Her clinical efforts are focused on the care of patients in medical intensive care units, including patients who have had COVID-19 over this past year. In addition, she's completing her master's in science with a focus on epidemiology. She's currently involved in ICU-based clinical trials and has served as a co-investigator on some of the COVID-19 drug trials we've gotten to hear about today. Dr. Levine also runs a post-ICU clinic where she cares for patients who required prolonged hospitalization in the ICU, required ECMO, extracorporeal membrane oxygenation, or were hospitalized for COVID. Her primary interest is in better understanding the various phenotypes of the post-ICU syndrome and assisting her patients in their path towards complete recovery. Currently, she has research projects looking at designing and running ICU-based clinical trials, ICU and critical illness outcomes, and the quality of life or survival after critical illness.
Well, thank you guys so much for having me here today. So I think my presentation is kind of about this idea that we've only seen the tip of the iceberg, which is hopefully not to scare anybody, but kind of just as a reality check of some of what I've seen in terms of COVID-19. So I used to read Time Magazine kind of religiously, and my favorite part of Time Magazine was always the by the numbers section. So just as a refresher for those of us who haven't been keeping up with them as much, about 185,000 patients in the US have been hospitalized from COVID-19 thus far. And the estimates are that about 25% of patients who are hospitalized will require care in the ICU. And those are the patients that I care for, oftentimes in our medical ICU, as was alluded to. And so that amounts to about 46,000 patients thus far who've required care in the ICU. And I think that that's a lot of what we see on the news. That's a lot of what we hear about. It's these biocontainment units that have been built, and it's transporting patients in their quarantine, and it's the masking and the gloving and the way to protect and keep the provider safe. And that is obviously critically important. Like I said, that's a lot of the bread and butter of what I've been doing the last 18 months. So I understand kind of the emphasis and the need to focus on this. But I think that this kind of overlooks something else, which is that there's actually more than 33 million cases of COVID-19 in the US, and this was data as of yesterday. So if you kind of take a step back and don't just look at that critically ill population, but look at the whole population, 33 million cases is kind of a staggering number. And then if you look at, again, what the data is coming out and showing is that about 50% of these patients are going to have symptoms of COVID-19 that persist for more than 30 days. And you may think, oh, well, those are just the critically ill patients who are in our ICU and they're on mechanical ventilation. That's simply not true. So a lot of these patients were non-hospitalized patients and they still have symptoms at 30 days. So about 42% are non-hospitalized patients. And then 30% of patients who have what they report as mild symptoms initially are having ongoing symptoms at 30 days. So this 50% of patients who have persistent symptoms doesn't just apply to those ICU patients who I care for. This applies to the larger population of people who've had COVID-19. And so the point of all these numbers is really that we're looking at 17 million plus patients who are going to have prolonged symptoms of COVID-19, and that's in the US alone. And so I think the critical care problem, the lack of access to medications, the uncertainties on how to treat these patients who are dying in the ICU on mechanical ventilators, that is a huge problem. But in many ways, it's really just the tip of the iceberg for what is to come. So just so we're all using the same language, this prolonged symptoms related to COVID has been called many things like post-COVID syndrome or long hauler syndrome, but the terminology that's most appropriate is the post-acute sequelae of COVID-19 or PASC. And then just again, so we're all defining it the same way, is according to the CDC, this is defined as symptoms of COVID-19 for more than 4 weeks. And that's kind of thought to be a subacute form. And if you have symptoms of COVID-19 for more than 12 weeks, that's more consistent with a chronic form. And this is not meant for you to be able to see all the numbers or read every single bubble on here, but just to understand that some publications are actually estimating that we may see 80% of patients having prolonged symptoms of COVID-19, but whatever the actual number is, whether it's 50% or 80%, this is a disease process that's going to affect multi-organ systems, right? And so we have neurological symptoms, including brain fog and confusion, memory loss, psychological symptoms like anxiety and depression, persistent pulmonary symptoms like shortness of breath, and cardiac symptoms like chest pain and heart palpitations. People complain of joint aches and muscle aches, lots of exercise intolerance. So it really can affect patients from head to toe and can involve any organ system. And again, this is not meant to really go through all of the finer details of this, but this is some research that came out of Nature recently. And really, it's just looking at what is the burden of disease and comparing specifically the burden of disease to patients who were critically ill with influenza. I think we all know by now that COVID-19 is not influenza, but just as a reminder over here on the right side, if you look at the relative increase in burden of disease compared to influenza at every organ system, and I had to cut off the table just so it would fit, but at every single organ system, the relative burden of disease is exponentially higher with COVID-19 compared to influenza. So don't be deceived. This is not influenza. This is not even H1N1. This is an entirely different beast. Similarly, in the same paper, they talk about if you look at the excess burden of disease in patients with COVID versus influenza. If you look at hospitalizations, the excess burden of disease is 28-fold higher. If you look at death in these patients, it's 28-fold higher. And if you look at outpatient encounters, it's 6-fold higher. So there's a tremendous burden of disease that's happening in people who've had COVID-19 and people who survived COVID-19, and it's lasting for a very persistent amount of time. So I just wanted to kind of quickly go through what I think some of the problems are based on kind of what you guys know now is this massive burden of post-acute sequelae of COVID-19. So the truth is there's simply not enough clinicians to see 17 million new patients. We certainly haven't trained 17 million new providers or any fraction even close to that. And so there's not enough providers to see these patients. And even if there were enough providers, there simply is not enough clinic space or appointment times or actual physical offices to go and see these patients that accommodate them. There's not nearly enough clinicians who have an interest in or an expertise in the post-acute sequelae of COVID-19. And this is not something that we're including in our medical curriculum readily. So we're not really increasing the number of physicians who have any expertise in this. I think just to reflect kind of what is a logistics problem, who should even see these patients, right? I told you they have multi-organ system involvement. So should they see neurologists or pulmonologists or cardiologists or all of the above? How do we identify who needs to be seen in a follow-up clinic? Who's likely to most benefit from being seen? Who is going to get no benefit? Who has permanent injury that's not going to recover? Who would get the most benefit from targeted intervention? And how should we triage these patients? Like I said, you can't fit 17 million in at a time. And of course, that number just continues to go up because every day we still have more cases of COVID-19 being diagnosed. I included here and tried to cross out all the names, of course, but this is my clinic schedule from yesterday. So I had a 3-hour clinic where I had 8 patients. All patients were post-COVID-19 patients, just as kind of a general gestalt of their symptoms. My first patient had been having shortness of breath for well over a year. The second patient was so fatigued for a year now that she was now unemployed. My third patient was on ECMO for 90 days in the intensive care unit and was recovering from ECMO, was actually doing very well. This patient was a firefighter who had dyspnea that caused her to take a leave of absence for 3 months from her job, which was now recovering. This patient's primary complaint was knee pain, so probably not in the right clinic since I'm a pulmonary doctor, but was referred because they are post-COVID-19. This patient had so much brain fog that they had lost a $100 bill with no recollection of where they put it, ultimately was found by their significant other in the refrigerator. And this patient had fatigue and chest pain that persisted for well over a year. So this is kind of the wide array of the different patients that are coming to a post-acute COVID-19 clinic or PASC clinic with their different complaints. And I think it just reflects, again, sort of the confusion in who should we see and who should be seeing them. I think on one model, you can see here, this would be kind of one type of multidisciplinary clinic that I think would be appropriate for a patient who is recovering from COVID-19. And this model, it might be hard to see, the patient of course is at the center of it, but I've included here a dozen or so different specialties that I think would be appropriate to take part in a multidisciplinary clinic, ranging from pulmonary to rheumatology to neurology to sleep medicine, pain management, PM&R. This really does encapsulate pretty much every discipline of medicine. I have patients who have vocal cord dysfunction and need to see ENTs. I have patients who have ongoing clotting problems and need to see a hematologist. So here, basically, you have a multidisciplinary physician clinic where pretty much every discipline of medicine is reflected here. And then I think in a different kind of multidisciplinary clinic, you have the physician who's seeing the patient, someone like myself, but then you have the other services which are also critically important, like physical therapy and occupational therapy, vocational rehabilitation counselors. Like I said, if you're a firefighter and you get COVID-19 and you're so short of breath that you can't return to work, it's really not probably fair that you're simply out of work permanently for the rest of your life, but having vocational rehabilitation counselors available would be critically important. So this is a different model of a multidisciplinary clinic where each of these representations here are critically important to the patient's recovery. But if you then blend the models together to really accommodate what the patient actually needs, this is what this model would look like, which is overwhelming, I think, because now you're looking at 20 or so different types of providers that are necessary to care for a patient just to recover them back to their baseline. So I think back to the logistical problems, how do you get a patient to see all of these providers? So now, in addition to one provider needing to find time and space for 17 million people, now 15 or 20 different providers each have to find space for these 17 million people. It's just not possible. It's not logistically feasible without training infinitely more providers. And perhaps maybe even more patient-centric is how do you get all of these providers together in one space to see the patient together instead of having a patient see 20 different providers, having 20 different providers be in one space and the patient comes there. That's also quite logistically challenging. I think we also have huge knowledge problems here. So as I said before, we really don't know who's going to get PASC or for how long. There's different reports in the literature that perhaps patients who are sicker from their initial COVID diagnosis may be more susceptible to prolonged symptoms related to COVID, although that's not always the case. Perhaps patients who are a little bit older are more susceptible to PASC. There are some proposed gender, race discrepancies between those who do and do not get PASC, but it's not entirely clear. And relatively speaking, we're very early on in the process of understanding COVID-19 and the process of recovering from COVID-19. As of right now, we don't have any treatments for these patients. So I can have a 17 provider clinic where a patient comes to be seen and I can do a full assessment, but I really don't have anything to offer them for their treatment at this point. And I think as we've learned with most things during COVID-19, good clinical practice and having the answers to what the best treatments are for these patients is really going to come through enrolling your patients in large randomized clinical trials, but there really isn't equitable access to this. So some cities and some hospitals, some programs are running dozens of clinical trials and others have no clinical trials running at all. And this is a patient population who's already somewhat disabled, short of breath, having mobility problems, they've been unemployed. It's not really reasonable for me to tell a patient to travel from Baltimore to a different city, for example, to enroll in a clinical trial. It really just compounds the issues that they already have that are underlying their current illness. I think without a doubt, hopefully I've been convincing that this is the next public health crisis. So I think coming on the heels of the acute issues with COVID-19 and our patients who are still sick and dying in the intensive care unit is going to be this massive population of people who require prolonged and very intensive and multidisciplinary care. And so I think, what are the pathways forward? So I think we have to have a systematic approach to follow up these patients. Perhaps something like a phone-based or virtual screening where all patients who are diagnosed with COVID-19 get some sort of phone call to ascertain whether or not they have persistent symptoms. Perhaps the first visit needs to be with the primary care provider. A systematic assessment needs to be done of the patient's needs, and then patients can be referred either to specialty multidisciplinary clinics or post-COVID clinics if necessary. I think that we need support and infrastructure to really build and run these multidisciplinary clinics that include all the disciplines that are needed for patient recovery. And I think we need to ultimately probably start to reward and incentivize trainees to do primary care, which has been a problem in medical education and training clinicians for a long time. But I think now more than ever, we're going to have a huge population of people who really need really diligent, thoughtful primary care providers who can assess what their needs are, provide them with long-term care, and refer them out to specialists when their needs are beyond what they can provide. I think we need a much more comprehensive dive into research. So I think that we need to better phenotype this disease process. So as I see in my own clinic, while all of these patients have a diagnosis of post-acute sequelae of COVID-19, there are different patients who were in our intensive care unit for 2 and 3 and 4 months who have arguably a different phenotype of the post-acute sequelae of COVID-19 than the patient who's been struggling with symptoms from COVID, but was never sick enough that they had to go to the hospital. Perhaps these are different diseases and these are different populations. They may mean that they need different kinds of providers, different kinds of follow-up, and maybe they're even different patients for interventional trials. I think in general, we need people to come to the table with bright ideas and suggestions about how to care for these patients. Certainly they need care from us, but I think if we don't do something to modify our current system or to work out solutions to provide them with support, we're going to end up with a lot of people who don't have the care that they need. So I'm hoping that hopefully this brings some smart people together to start to brainstorm what we can do to better provide support for these patients.
One thing I kind of wanted to ask you, I think this kind of was touched on in each of the presentations, is that it seems like, especially for a new infection, information, especially in the very beginning, was very limited. And then people were getting inundated from information from a lot of different sources. And so I kind of wanted to ask you, sort of from your own perspectives, and maybe Pat, we can start with you. It's kind of, terms that were fairly niche before, like, emergency use authorization, or the ins and outs of FDA approvals, or off-label, on-label, different indications, or, non-reviewed medical preprints. Now everybody kind of has access to. All these things have changed so much through the pandemic. How have you each kind of navigated the flow of information to find the most trusted sources? And then in your own fields, how have you managed to kind of establish yourself as a trusted source of information for patients or for collaborators?
So I think for us, we're in a position as being a trusted source from the get-go with the patient community. So we've really been trying to translate a lot of the communications that are out there and trying to put it in, particularly for patients, to give them a one-stop place to go to answer all these different questions, so that they're not searching for different sources, which may be giving them different types of information or different definitions. And so that's been the main focus that we've had in communicating with the patient community, is really trying to make sure that they have a trusted place to go to get answers about all different types of questions. And the way we're structured is we have professional health educators that number of cases are nurses that do have some medical training, that certainly do have experience working directly with patients that are not only providing information, but also listening to what patients are saying. What do they want to hear? What are the questions? So throughout the pandemic, we've been very aggressive about trying to see what the patient needs are and trying to fill those needs and being proactive to getting the information out to patients so they don't necessarily have to go searching for it.
Andy or Angela, do either of you have a perspective on that?
I think a lot of the medical preprints and some of the way that early information was disseminated through social media was really probably very harmful to the way that we cared for patients. I remember very early on, I was attending in our medical ICU and I had a fellow who was with me and he was getting, Twitter and Facebook and Slack messages that were sort of continuously going off. This was maybe in April or May. And really saying things like, well, we have to give this patient zinc, we have to give this patient hydroxychloroquine. And I had to sort of remind him that our job as a physician is really to first do no harm. And I think it's often hard for doctors to do nothing, right? To just sit there and do nothing. We didn't have anything for this virus. We didn't have anything for these critically ill patients, just to really kind of put your hands behind your back and say, well, I know how to provide supportive care to critically ill patients with ARDS. There's been decades of evidence on how to do that and do it well. That's what we have to stick to. And I think that it's been really challenging for many of us to kind of stick to the fundamentals of first do no harm and practice evidence-based medicine. I think it's imperative for us to kind of teach our trainees to continue to do that. I think that if you read some of this information but take it with a grain of salt, it's not harmful or detrimental. But I think if you read Twitter posts about ivermectin and hydroxychloroquine and you start to indiscriminately provide those to your patients, you really are at risk of providing them or putting them in a lot of harm. And I think now I'm getting a lot of pressure from the patients in my post-acute COVID clinic. Well, give me this, or give me more steroids, or how about these medications, or how about these supplementals? I think it's our responsibility to stay up to date on the data. Have no data behind them. For me, I make it very clear to the patients at the very first visit that I don't think anyone is an expert in COVID-19. I think that we're all kind of learning about this disease process along the way, and that the same analytical eye that we always do. And I think starting the clinic like that maybe helps set expectations that there's not going to be a magic bullet. There's not going to be sort of anything that's I can hand them just to cure them, but this is going to be kind of a journey of discovering this process together and of diligently reading and exploring the work and the research that's coming out.
Angela, kind of where did you see your information sources change and how did you kind of navigate that?
Well, for us, we at Humana as a whole, because we work with our chief medical officer, looking, to the public health guidance and the infectious disease experts, really, what is the CDC and, what are they telling us? And our focus was really just on trying to encourage people to listen to the public health guidance and then keep our members safely at home and get them access to the things that we could provide them. Like I said, make sure they have their medications, make sure, if we could get them telehealth visits, that sort of thing. But we were just encouraging people to follow the public health guidance on this emerging topic, right? Because we certainly weren't going to speak to it because we weren't the experts in it.
Yeah. Well, and so kind of piggybacking on that a little, we mentioned, you mentioned the number of telehealth visits that Humana saw, during this pandemic and how that increased over time. And I know a lot of other people, got much more comfortable using, telehealth or, being in contact with, collaborators who weren't in the same space or, somebody in the first session mentioned, some of the virtual ways that we had patient visitors, when patients were very ill, to sort of navigate end of life issues when visitors weren't able to come to the hospital. How do we kind of continue some of those and maybe even maximize some of those, sort of post-pandemic? How do we maintain some of those things that worked? How do we bring more of those in? How do we kind of keep that going and help it grow?
Well, I guess I can take that first. And I think certainly telehealth, there's going to be more of that, but also with an eye toward equity. We have to think about how do we expand access to broadband. That's something that's on our radar to make sure that people have those kinds of capabilities, that they have the broadband access, but also they need someone to help them get set up and using that comfortably, right? Because that also is a barrier, a health literacy or education or technology education barrier. So we know we'll have to cross that bridge as well. But I definitely see more of that. I heard Patrick mentioning and also Dr. Levine mentioning multidisciplinary care team approaches, and that's we have those kinds of models that we're putting in place. We have a lot of home care assets, so we're figuring out how do we deliver care in the home where people want to be, and physically, as we're able to safely go there again. So those are some of the emerging models I think that are going to continue to grow.
Yeah, I'll just add to that. The telehealth, it's certainly been a benefit throughout the pandemic, and it is. I think it's only going to grow in terms of its use, post-pandemic. There's a lot of challenges there, particularly on the policy side and reimbursement side, and the issues that need to be addressed there. But then there's also just making sure telehealth is the right option for the right patient at the right time. And that's, in our case, there's certainly times where it's appropriate and needed, and there's times where it's not. It should be a replacement for it, for an in-person visit. And then Angela raised an excellent point, which we found, what's a challenge is just the issue of equity. And there's certain communities that just do not have access to telehealth or aren't familiar with the technology. And so that creates as we create this new or relative or potentially expanding opportunity to provide more access, we don't want to shut out other people at the same time. So that's something we just need to bear in mind, and how we can use this to really enhance access to care for everybody, not just people who know how to use the technology and have access to it.
I will say that I very much hope that reimbursement for telehealth is something that continues. I think it was pretty quick after the pandemic that we started to get told that we could do visits via telehealth, and that the reimbursement was equal for telehealth visits as it was for inpatient visits. And I think there's some concern that that's going to go away as the numbers go down and the pandemic is over. And I think that while there are certainly communities that we're not reaching with telehealth, I'll say for me, I see patients who came out of our NICU or patients who are on ECMO. These patients are often flown in to Baltimore from all over the state of Maryland. It's really unreasonable to expect these patients who are still suffering and have ongoing disability to commute back into the city, park, walk from the parking garage, come into my clinic, lug their oxygen around, take more days of work off, have their family members take more days of work off. So I think using telehealth has really allowed me to get into the patient's home. And that also allows me to interact with and see their family and engage their families in their care. So there's been a lot of, I think, perks of telehealth. I think there's also a lot of potential for using telehealth to really serve as the infrastructure for these multidisciplinary clinics as a way to get people kind of all together without having to have that actual infrastructure and office space to bring a patient into 20 different providers' offices. And so I hope telehealth is one of those things where I had been asking for telehealth in my clinic before COVID happened. And I hope it's one of the things that we've learned our lessons, we've seen the value of it, and that it doesn't go away just as the numbers of COVID patients kind of comes down.
Mm-hmm. Well, and that actually kind of gets to something that you touched on in your talk, and then a question that somebody had posed, about when you think about the three sort of models of care that you proposed, and having, interdisciplinary versus, intramedical disciplinaries, all the different medicine discipline, plus, some occupational and other kinds of social support, and then other kinds of patient support, kind of bringing all those in. Do you see good sort of processes for trying to set up those clinics now, or do you see a way forward for that? Do you see people starting to do that in an effective way?
I think, yeah. So, I'll say one thing is that many of the post-COVID patients or the PASC patients are being seen in clinics that were initially built, like mine, as a post-ICU clinic. And so those clinics were already built and have many of those multidisciplinary services incorporated into them. So pharmacy and physical therapy and social work. And so as patients continue to be seen in that infrastructure, those services will be offered to them. I think the other type of infrastructure these patients are often seen in is like a translational care clinic. And so like in that model too, a transitional care clinic often has pharmacy and social work and case management. And so there are opportunities to provide patients with the support they need using those models. I think the other model some of us are trying to use for our clinics would be like what you would see in like an ALS clinic or like a Lou Gehrig's clinic, where you have neurology and rheumatology and pulmonary and all these different medical disciplines present. And I think a lot of those clinics, when COVID happened, started to run all via telemedicine visits, and it became a really interesting setup that I think has actually become very efficient, where you have 8 or 9 different providers on all at one time. The patient joins the visit, and then all of the providers can kind of hear the story and the update straight from the patient's mouth without the patient having to go to 8 different providers and recount their story and their symptoms and their progress. And I think that, if we continue to use telemedicine, that is the one way that we can get all these providers to see these post-COVID patients at one time. And it's really a patient-centric approach where we're not asking the patient to kind of be paraded around to all these providers and tell their story over and over again. It's bringing us all together really to see the patient in an environment that's comfortable and accommodating to them.
I'll just add to that. It's interesting, as Dr. Levine, as you were mentioning, and you mentioned ALS, and that was, I spent the bulk of my career in that world, and that is the model. I mean, that's how people with ALS are cared for, but in other diseases, it's not the model. And I think that is a challenge. And I know in lupus, that's a direction we want to go. We're not there yet. And, that is, potentially a silver lining that we, from this experience, is we are learning that this just reinforces kind of the need to move in that direction, I think, across the healthcare system.
Yeah. Well, and how do we continue to reimburse that? I mean, especially when you think about PASC, where there's not an ICD-10 code yet, and where we're all sort of a little bit kind of operating in this kind of still transitional phase of this is how telehealth works for now, but it might not continue. And especially, Angela, you might have insight in this. How do you kind of reward that sort of interdisciplinary care to help continue to make it possible?
I don't know that I can speak for all of that, Humana, but we have a great portion of our members in value-based care provider relationships, risk-bearing, kind of outcomes-based models, payment models. And, so often the successful providers in that space have their own kind of holistic approach to health, that they are, you look at groups like Iora Health, for example, that are providing supportive services like transportation or food services within their clinics and coordinating, a really coordinated kind of care model and producing these help lift up these quality outcomes and health outcomes. So that's one way at it. And then when we look at social needs, we're actually doing work. We have a partnership with the auctioneer system in Louisiana, where we're actually paying the providers to screen and code for health-related social needs, because there actually are ICD-10 codes for things, I think, in the family of 55 to 65 for food insecurity, social connections, and a few others. And we're also working across the industry to get more granularity in those codes and to try to tie the social risk to, even further to clinical outcomes, because ultimately we think that there may be a pay model difference in the health system for addressing those things that are also impacting health. So that's kind of just, there's a lot going on. I mean, we could talk just about payment models and things, but those are some of the things that we're looking at.
Yeah. Well, and one thing that I found particularly interesting when you were talking about some of the different models and programs that Humana specifically put in place, PAPA and some of the others, and sort of how you followed the outcomes of those. And so I guess that's one question I have, kind of about some of those those programs or about some of those initiatives is how do you over time follow their success, especially as society and the pandemic and how much we're open and how much we're closed, kind of changes. How do you assess those programs, and how do you decide how long they continue?
Yeah, that's a real challenge when you're trying to launch some randomized control trials in the middle of a pandemic, and one of your outcomes measures is like utilization. Yeah. when people aren't going to the doctor as they normally would, right? Yeah. No, but our general approach to, sometimes we're testing things out as a planned benefit, like supplemental benefit, SSBCI, or a value-based insurance design kind of supplemental benefit. In that case, you can't even do an RCT. You have to do something because you have to offer it to everyone in the plan. So you might do something where you're propensity matching to another plan. But we're looking at early indicators, leading indicators like healthy days, and are we ameliorating those social needs as sort of, early on, and saying, okay, is it heading in the right direction? Then we start to look at some of those quality indicators, whether it's preventive screenings or, lab values, things, or medication adherence, are those things improving? And then looking at, in the interim, and then looking at the long term, which may need to be a longer run out. Do we see a difference in propensity to, or likelihood that they're ending up in the hospital or being readmitted, or, other markers of disease progression, for example? So that's our approach. We are scaling up some large randomized control trials though, but, obviously COVID complicated things when you want to have, healthcare utilization and cost as part of the mix when the last year was so crazy. I hope that answers it a little bit for you.
No, it absolutely does. And actually, since you mentioned research and you mentioned RCTs, I kind of want to ask all three of you, especially when you're thinking about, treatment trials and randomized control trials, when you're thinking about, studies of PASC and kind of what to expect after people recover, when you're thinking about sort of models of whether people are getting their needs met, those kinds of things require a lot of collaboration. And one of the things we talked about throughout this this whole conference, the first session and now, is, kind of how we maintain engagement, how we can foster collaboration and communication virtually when we can't all get in a room together and just hash out how these things will happen. So I guess one thing I would kind of like to ask is, how did you sort of professionally manage still being collaborative, as you were kind of working towards these goals during the pandemic, and how do you see that, how do you kind of see that maintaining after as things start to open up again?
I wish I had the answer. I think, speaking for me personally and just our organization, it took some time to get used to everything. And now it's interesting is that now that everyone's really used to doing this now. It's weird when you have a conference call, as opposed to a virtual meeting. So I think it's gonna take some time to figure out what is the right mix, to continue to leverage the best of both worlds, the in-person world and meeting technology like this. And it's gonna take some time, I think, and it's and there's gonna be some trial and error and what works, what is the right mix. It's certainly not going to happen overnight. I know we're struggling with how exactly we're going to be open and what that looks like. So it's going to take some time, but it's certainly not going to go back to the way it was.
I think, we've been a little bit lucky. Like Eleanor, I see you at work, and I still go into the office every day, and I didn't start working from home because of COVID. And so I think in some ways we had to be more collaborative than ever. We went into the hospital and we relied on each other, and we saw a need to further define what these patients needed, both in the hospital and out of the hospital. And we found within each other, I think, a network of people who were interested in studying COVID-19 and interested in treating patients with COVID-19. And just like you and I have collaborated, we kind of, I think, defined this network at our own institution of people who were interested in studying this disease process and doing research on patients with this disease process. And then I think you kind of watch that network grow to be local at University of Maryland, for example, but then like I'm part of a network of post-COVID, post-ICU clinics where we meet once a month. virtually and really kind of bring together our ideas based on what we've seen and what the phenotypes that we're seeing are, how to address some of these issues with getting patients in and providing telehealth visits and doing multidisciplinary care. I think people more than ever want to collaborate. They want to support each other and be there for each other. I think people are identifying that there's a huge need to work together to really provide the care that patients need. So I think there's been some new things that have to learn to use technology, but in many ways, I think the collaborative environment is richer than it was before COVID.
I hope so.
Yeah, I agree with that. I mean, I think we'll have, I mean, from my own point of view, I think we'll have kind of a hybrid model of engagement going forward. I mean, in a company like ours, we have people all across the country who are, working together anyway, but we did have a lot of in-person meetings pre-COVID. I think that there's such value in getting people together in a room, or even just being around, doing more informal, whatever, water cooler kind of talk, right? The drive by your office and, hey, I had this idea. But I think we've also, used technology in innovative ways to, it was kind of forced on us to be innovative. And how do you work from home with, your pets and your kids and all that kind of stuff happening around? Humana did a really cool thing, actually, partnering in Louisville, our headquarters, hometown, set up offices in parks. When we felt, later last fall, late summer and fall, when cases were at a certain level, we felt it would be safe for people to go out in smaller groups. They set up outdoor office spaces with technology and wireless networks, and we maintained social distance and wore masks, but people were able to gather in small groups and meet in person, occasionally, and it was they limited it to like 10 tables of a handful of people a piece, but it was so valuable. Like, people were just hungry for that, and so much good came out of it.
No, I could see that being, people being so excited to collaborate and then also get a little bit of nature therapy when they're there, and kind of, I bet it was emotionally and professionally satisfying.
I think we're going to do more of it, actually, even, in the future, pandemic or not.
Yeah. One thing I kind of want to ask too, I think maybe as an infectious disease specialist, I think about this a lot more because I treat patients with HIV, I treat patients with hepatitis who have to talk about some very stigmatized behavior and other things. And I think that's something we've seen change and evolve a lot over the COVID-19 pandemic too. There's sort of, in the beginning, I think there was a lot of fear, probably still is. And then as things shifted towards talking about factors that made people maybe predisposed to more severe COVID, particularly obesity or other kinds of comorbidities, I think we've seen a change in terms of thinking about privacy. And I wonder if that's something that you guys have seen in terms of that sort of battle between, or that struggle between stigma and privacy and getting sort of information from patients. Is that something that you've seen change over the course of the pandemic? Is that something you've wrestled with? I don't know. I'd take a minute to think about it, or if it's, I don't know if it's.
We're not collecting patient data. A lot of our interactions at a different level, so we're not. Our direct interaction with patients isn't necessarily collecting that type of private data. So if anything, I really haven't seen a change in terms of either people having less concerns about privacy, or I still think it's there. Even I'm thinking about, you mentioned trials earlier. A lot of what we do, or a good part of what we do, is really to try to advance research and advance drug development, and through participation in trials. And COVID or no COVID, there's still the same concerns when it comes to privacy.
Oh, sorry, I didn't mean to interrupt.
No, go ahead.
I was just going to say, is that something you've seen change with people involved with the Lupus Foundation, that they're forced to share that they are relatively immunocompromised? I think about how visible some of the debates we've had over like masking are. And so are people maybe forced to share their immune status or their lupus status, maybe when they wouldn't have, if they feel like they're, at risk? Or is that something your members have vocalized?
I haven't heard a lot of it. I think it to a certain degree, people are more comfortable because it's been talked about. Mm-hmm. And especially in the context of hydroxychloroquine, lupus was, part of the national conversation through that situation. So I think there is some level of comfort there talking about it. I still think there's concern, particularly when we're, on the employer side, there's still some concern there, because people were hesitant to talk about this. But it has helped. I think it's going to be helpful in the long run to make it easier for people to discuss these issues, because people can, I think there's a better understanding now. Just for example, I had mentioned flu season, and I know there's a huge difference between flu and COVID, but people were, they didn't really want to talk about the precautions that they needed to take for flu. I think now they're probably more comfortable to talk about it because everyone understands it. Because with COVID, it was life and potentially life and death for everybody. And so I think more and more people can relate to the situation that people with lupus live with every day of their lives.
Yeah.
Something that comes up in my clinic often is a vaccine status, for example. And I don't know if this is the way it's always been with vaccines like the flu vaccine, but it's pretty publicly available to clinicians to see if patients have been vaccinated. It's part of their medical record for the most part, and there's vaccine databases that you can access and see if the patient's gotten vaccines, which is great because I think all of us are being hyper vigilant about possible side effects and sequelae of the vaccines and reporting those things to the FDA. So it's important to know if your patients have been vaccinated and with what. But I also try to have conversations with all of my patients who are not vaccinated, I think, about pursuing a vaccine and doing so quickly, even though they've all had COVID, sort of reminding them that it doesn't mean they can't get it again or they won't get sick again from it. And I think that's something that I'm not accustomed to as a physician, is having such easy access to someone's vaccine status. I never knew if my patients got the flu vaccine in the past. I wasn't particularly interested in it. I would encourage them to get the flu vaccine. If they refused, that was kind of the end of the conversation. But I think it is interesting how much access now we have to the vaccine status and some of the stigma and conversations that have arisen from that component of this.
So, more anecdotally speaking, and observationally in the last month or two, so I had a specialist doctor, my dermatologist, who said, I foresee us using masks, at least within clinics, as more of a universal precaution going forward. I'll be interested to see if that happens. Just like we're always gloving up, all these kinds of things. Would we, in a healthcare setting, a doctor's a primary, I think about my pediatrician's office, there's like a well entrance and a sick kid entrance, right? But do they just start saying, in the healthcare setting, because you never know who's there, do you take on some more of those universal precautions? Maybe, I don't know.
Yeah. I enjoyed not getting a zillion colds from my 8-year-old this year. I know other people probably did too. So since you brought up the vaccine, I think that's one pivots a little towards something I really wanted to ask too. And I think all three of you might have very different perspectives on this, but COVID care and vaccines and testing all set up a new model within American healthcare, right? I mean, it was something that for the most part, most patients didn't see costs associated with that. I know there were costs associated with it that were borne in different ways, but patients didn't often have to have a copay or a bill for that. And so how do you see that going forward in future public health efforts? Is that how we express, sort of our priorities in terms of how that gets unrolled? How have patients received this? How has this mattered to people? I'm curious about how we see that changing and changing our conversation about healthcare. It's a big question, sorry. Oh wait, Angela, I think you're muted again. No, you were, intentionally muted.
I was just saying, wow, that's a big question.
It's a big question. But I think from a patient, from a provider, and from sort of, a payer perspective, I think this has implications for all of our work. I'm curious about what the conversation has been about how that might change.
I sincerely hope that this model continues. I think having no payment involved in getting vaccination is a reflection of the priority of the healthcare system on vaccinating the patients. And I think that kind of takes off the table inequities and people who can't afford to get a vaccine or who don't have health insurance. Everyone has access to it. initially it was kind of limited by your age, but increasingly more and more people have access to it, and not having a price be a component of this, I think is absolutely critical. I think if we want people to get vaccines, if we think as a public health initiative that this is important, we have to take away their ability to shy away from it because it is financially prohibitive. If at the end of the day you have to choose between feeding your family or getting a vaccine, you're going to choose to feed your family, and it shouldn't have to be that choice.
Yeah, and I definitely agree with that. I think we can take a look at how the processes work, what barriers we broke down, how we can translate that to other things. And cost is certainly one of those barriers, but there's other transportation and access. So what else can we do in other parts? Whether it is something like telehealth, or what else can we do to really improve care and just reduce the barriers? What worked with vaccines that can work elsewhere?
Yeah, I mean, the big picture, I'm thinking about things like the whole system of quality. You think about the STARS quality system, for example, and that flu shots is a great example. Flu shots are actually in the CAPS, Consumer Assessment of Health Providers and Systems survey, but that is a quality measure, that a lot of payers are working on. How do we make sure that people are able to get flu shots? And in most cases, I think there's no cost really to a health plan member on getting that flu shot coverage, at least from our perspective, and dealing with a lot of Medicaid and Medicare members. So it's, I guess, big picture is that the whole system as a whole is saying these are priorities, right? And if you think about so much preventive care that was, that came through the Affordable Care Act, and preventive screenings, breast cancer screenings, and colon cancer screenings, those kinds of things are quality metrics and are important for everyone to advance. And so there's policy guidance around it, and I think that helps as well.
Well, and since everybody mentioned the flu, I think that's one thing that is interesting. We've had ways to prevent the flu before by, trying to increase access to flu vaccination. But it wasn't until this year with the COVID pandemic, knowing that they're separate, but that we really saw flu cases fall because people were masking, because people were staying home. And so realizing that, the flu pandemic every year, or the flu epidemic every year is almost a choice. And we've sort of learned some of the things that can really impact that. Do we see that changing? Do we see, do we think we've learned from the management of this epidemic? I know, sorry, another big question. Do we think we've learned from the management of this epidemic and what's happened to flu, what's happened to COVID, what's happened to vaccine information to kind of go forward?
I hope it was a win, for public health. I mean, that is relatively long lasting. I mean, I don't know how history repeats itself. If you think about other infectious disease epidemics like polio, right? In the 50s, for example, when, kids were staying at home and not going out and about to avoid the spread. Like how long will it last? I don't know, but I hope that, if we've learned anything, it's like, how gross is it to touch the elevator button, right? And then like touch your face afterwards, right?
Yeah.
The one thing I'll say is I don't think it's as much of a concern as it was earlier during the pandemic. Is we were concerned that things may go, the pendulum may move too far to the other side of caution. In that, and I don't think it's as big of an issue now, but there were concerns that when we reopened, that there would be restrictions about being able to access public buildings or whatever, where you can't have a fever. We certainly saw no fever, no symptoms. The challenge that we had is those are symptoms of lupus, and we didn't want to make sure, we were very worried that might bar people with lupus from participating in things just because they have lupus and not COVID. And so we're sensitive to that. I don't know that it's as big of an issue now as I thought it might have been, but it's still something we're a little bit wary about.
Thank you all so much for being involved. I really appreciate your contribution, your time, and your willingness to come on here and answer questions and share with us. We've learned a lot throughout the session and throughout this last 18 months too. And Joey and I in particular have learned a lot about putting on a virtual conference. So I want to thank everybody for being involved. Thank you from the bottom of my heart.
All right, with that, I just want to say thanks again on behalf of the University of Maryland, both the Patients Program, the Institute of Human Virology, and everyone here today. Thank you all for attending. Obviously, stay engaged, and we hope that we've convinced you that patient engagement in comparative effectiveness research is a great method to help go after the outcomes that our patients care about and improve infectious disease research. So thank you all.